Hello class. So my clinical pearls PowerPoint is on hyperthyroidism. The objectives of this PowerPoint is for learners who will be able to define hyperthyroidism. Learners will be able to describe the underlying pathophysiology of hyperthyroidism. Learners will be able to identify common causes and risk factors for hyperthyroidism. Learners will be able to recognize the signs, symptoms, and potential complications of hyperthyroidism. Learners will be able to discuss the diagnostic evaluation, including laboratory tests. Also, learners will be able to compare available treatment options for hyperthyroidism. So, the pathophysiology. Normal thyroid function is regulated by a feedback loop. The hypothalamus releases thyrotropin stimulating hormone, which stimulates the anterior pituitary gland to secrete thyroid stimulating hormone, which we're all pretty familiar with, TSH. So TSH promotes the thyroid to synthesize and release T3 and T4. Hyperthyroidism occurs when the feedback loop fails and the thyroid gland produces and releases excessive amounts of T3 and T4. The high amounts of T3 and T4 suppresses the TSH. In hyperthyroidism, the TSH is low and the T3 and or T4 is elevated. Graves' disease is an autoimmune disorder and is the most common cause of hyperthyroidism. Graves' disease most commonly presents between ages 20 and 50. Common features include diffuse enlargement of the thyroid, hyperthyroid symptoms, which we will discuss coming up on the next slide, and eye bulging. So in the picture on the right, you can see how a healthy thyroid gland would look versus the goiter that you would see or the enlargement that you would see in Graves' disease. So some risk factors include female sex, family history, smoking, iodine exposure, neck radiation, and person with a history of autoimmune disorders. So clinical presentation, again, this is similar to Graves' disease, as you can see the picture on the right with the healthy thyroid versus the overactive thyroid. But some clinical presentations that you may see is a patient presenting with weight loss, females with menstrual irregularities, muscle weakness, heat intolerance, palpitations, tremor, anxiety, insomnia, fatigue, and increased bowel frequency. And a lot of these symptoms can correlate with other disease processes as well, so it's important that as practitioners that we really investigate these symptoms and say, okay, what's the root cause of this, because you may see these same symptoms in other diseases. Physical findings, if you look to the right, you can see that picture again, the exophthalmos, where you have the bulging eyes. That's something that we talked about in Graves' disease. But physical findings includes tachycardia, systolic hypertension, fine tremors, warm moist skin, weight loss, goiter, exophthalmos, hyperactivity, and hyperreflexia. So one thing, whenever we think about hyperthyroidism, you want to think your hyper is kind of speeding everything up. So your heart's beating fast, you're shaking, you're jittery, like when you're nervous. Weight loss, it's kind of like you're working out, so you're losing that weight, and hyperactivity and hyperreflexia. So everything's kind of sped up. Thyroid storm, this is a potential complication that you see in hyperthyroidism. It's also known as thyrotoxic crisis. So this is a life-threatening emergency when there is a sudden increase in thyroid hormones. Typically, the way you see this presented, patients may have high fevers, they may have, their heart rate will be elevated, they have severe tachycardia. Sometimes they will present with atrial fibrillation, hypertension, agitation, delirium, diaphoresis, nausea, vomiting, shortness of breath, and in severe cases you may see heart failure or pulmonary edema. And I've seen this before, and I've treated patients like this in the ICU. So like I said, typically this is in an ICU setting. You would treat with beta blockers, thiamides, glucocorticoids, and potassium iodine. And we'll talk about those treatments a little more. So the diagnostic criteria in testing, diagnosis is made when the thyroid stimulating hormone is low. So the T3 and or the T4 are elevated. So you would rule this out through laboratory testing, and you want to test a TSH. Typically, you get a baseline with the TSH, and then if that's out of whack, then that's normally when you can do a free T4 or a free T3 to see kind of what's going on. But when a patient's presenting with all these symptoms, it's no problem to just go ahead and get all of these lab tests done. So pharmacological treatment, as previously discussed, beta blockers are usually started as soon as hyperthyroidism is diagnosed, as long as there's no contraindications. First line beta blocker that we typically use is propranolol. So you can use propranolol first line. We also use thiamides like methimazole. That can be used in conjunction with a beta blocker for definite therapy. Iodine can also be used as adjunct therapies. So you can use these pre-op, probably before a patient gets their thyroid removed, or in this case you have non-pharmacological treatments, and that would be surgery or radiation interventions where you have radioactive iodine and it's selective to the thyroid, and it kind of kills those overactive thyroid cells, or you can get a thyroidectomy. So those are options as well. And these are my references. Thank you guys. I hope you enjoyed this PowerPoint.